So without further ado, if I can have Dr. Shereef Elnahal to, the detailed bios are in the attachments or in the downloads. And if I were to spend time introducing them, we probably won't have too much time to hear them speak. But Dr. Shereef Elnahal is the president and CEO of the University Hospital Newark and former commissioner for New Jersey Department of Health. On a personal note, he was also the keynote speaker who helped us kick off the cohort study a few years ago back in the Institute. So we're really delighted to have you today. So Oliver, if you've pulled up the slide deck for Shereef, thank you very much. I'll put myself on mute.
Good morning. Thank you so much, Shinshi, for the invitation to speak to this group. And it's a very distinguished group. I recognize a lot of names here in the Zoom and really just appreciate everything the Practice-Based Research Network is doing. When I was health commissioner, I mentioned how important the larger cohort study effort was to public health in New Jersey, and I maintain my optimism for that. I think it's a great team behind it, which is the most important thing, but also, a team that has the expertise to drive really just incredible insights that will surface and really accelerate over the next few years because of that effort. And so when I was asked to present what we're doing at University Hospital regarding ambulatory care, but more importantly, how our ambulatory care efforts contribute to healthcare quality, patient safety, but most importantly, community investment. And so that's where I'll start with this presentation to emphasize why I view the reason I'm here and why this hospital exists. A quick summary of the history of this place dates back to a community that was displaced by this campus, which is now occupied by both University Hospital and Rutgers, New Jersey Medical School, School of Dental Medicine, a number of other Rutgers professional schools who we partner with hand in hand to advance healthcare here. And that was one of the most prosperous Black communities in the country. In fact, it rivaled the success of the famed Black Wall Street in Tulsa, Oklahoma. We saw the president there speaking about the really just terrible injustice with the massacre that happened against Black people and families there just about a century ago. And while similar violence didn't occur here, there was certainly an injustice placed on this community, which was that of eminent domain that displaced an entire community. And again, one of the more prosperous communities in this area, and certainly in the city, and among the most prosperous African-American communities in the country. And in return, the hospital and the campus was supposed to reinvest and serve the community. And unfortunately, that history has been patchy since the beginning. The entities here have gone through several iterations, structures, formulations. At the end of the day, it is a hospital and a medical education infrastructure that was always supposed to serve the community, was always supposed to grow its services and meet the growing healthcare needs of the community, and was never meant to be simply an area of academic investigation without community investment, and certainly not an area where services should be curtailed. And so that's been my agenda since I've arrived, to increase services here, knowing the deep healthcare needs of the community we serve. And we have 75%, proudly, 75% market share in the city of Newark, and proudly serve the most vulnerable in Newark. But to not grow and proliferate and provide more and more services over time would be a direct, frankly, a direct violation of the Newark agreements, which surfaced after an episode of violence overtook this community in a different period of racial reckoning than the one we are experiencing now. And those were violent riots that caused unrest. And part of the way that unrest ended was a rededication and a repromise of this campus to its community. And so I have the Newark agreements, which codified those promises, on my desk. It's the first thing I see when I sit down every morning. And it is the last thing I see before I leave. And that's purposeful because it reminds me why I'm here and reminds me what my agenda is centered on, and really nothing else. Next slide.
That's great.
So I want to just describe a little bit about who we are. We are a provider that sees quite a few patients. We have over 15,000 inpatient admissions every year, but importantly, almost 200,000 clinic visits. So we really engage our patients predominantly in the ambulatory care setting, which is where much of the primary and preventative care is likely to take place, and where we think that moving the needle on the social justice and population and public health agenda is most possible. We also perform over 11,000 surgeries a year, and have over 83,000 emergency room visits. But what I like to always say is that if we do our jobs right, we will create a system whereby our clinic and ambulatory care and in-community visits go up over time, and the need for acute care goes down over time, which sounds pretty counterintuitive for a hospital CEO to say. But if you have the right relationships with payers and you have the right policies behind such an agenda, you can finally make this sick care system into a health system, and really start to improve the health of communities that surround us. And so that is our agenda. We have to be very careful about it because we have to be a sustainable entity. And so, of course, that pressure always exists. But I'm proud to say that despite, I'll say the word despite because it's just operative in the sentence, even though we focus so much on community and population health, we've managed to generate a positive margin here for the first time in many years, because of the trust we've built in the community and the trust, very importantly, that I've built with our staff to increase our efficiency and see more patients. We are a level 1 trauma center. We are a principal teaching hospital of the Rutgers Biomedical Health Science Schools. And we have a great partnership with the medical school and dental school and other professional schools who are now prioritizing this campus and the mission here in great ways. We're the first hospital and medical campus in New Jersey to handle COVID-19. We quarantined the first patients who had been through Wuhan, China, and wound up in the Newark area. And fast forward across the time span of the pandemic, we faced a surge where essentially almost 100% of our hospital capacity was caring for patients with COVID-19. We were the first hospital to administer a COVID-19 vaccine outside of a clinical trial in the state, but we were also one of only three campuses doing clinical trials on the now extremely effective and safe vaccines that are currently on the market. We're also, very importantly, the provider of emergency medical services for Newark, Orange, East Orange, and Camden. We also cover Newark Airport for those services, and so have a much bigger mission than just being a hospital for acute care. Next slide. Our service population is one with deep social need. And just to give you a picture of that, we have a higher percentage in Essex County of the folks below the poverty line. We have always had a higher unemployment rate than the rest of the state, but that gap, that disparity between Essex County and the rest of the state has grown during COVID-19 with all the economic pressures that it has brought. Median income is lower than the rest of the state. And we have a very importantly, a pediatric population that actually is greater than the rest of the state. And so we are a younger market and service area overall than the rest of the state and the general population. And very importantly, very high proportion of folks we serve are racial and ethnic minorities. The region itself is almost 70% racial and ethnic minority across the county. That number is, of course, higher for Newark, Irvington, Orange, and so many of the other towns that surround us right here in our service area. Next slide. And just to give you a sense of our demographics, in particular with our ambulatory care clinic, we've served uniquely over 50,000 patients a year. So again, really drawing from a large population right here where we serve. And over 70% of our patients are either Black or Hispanic. If you include other ethnic minorities, ultimately, well over 90% are people of color who we serve. We also serve the median age group is between 44 and 64. So we have a younger population on average than most hospitals. And we have over 65% of our patients either carrying Medicaid or charity care or self-pay. Self-pay really just meaning that they don't qualify for charity care and we have to subsidize their care here. But we do so proudly because that's part of our social mission as a public hospital. Next slide. Just a little bit more about specific to chronic diseases, what we see here. We have a high prevalence of diabetes, obesity, smoking, more so than the rest of the state. Poor mental health days, infant mortality is higher, and drug deaths, of course, in Essex County historically have been higher and have been much higher, unfortunately, throughout this pandemic. HIV is a particular problem in the city of Newark. It's gone down, not nearly at the pace as the rest of the state. And a lot of our work in having the governor announce an initiative to end the HIV epidemic was focused on efforts that have been ongoing in Newark. And Dean Johnson, here, Dean of our medical school, has been a leader in this effort for decades. We're proud to work with him and others to advance that cause. Of course, during COVID, we faced the worst of it here, right here in the New York metro area, compounded by a community that has a higher prevalence of chronic disease, which predisposes to worse outcomes if you contract COVID-19, but also a higher likelihood of contracting COVID-19 because of a higher representation in the essential workforce, a more densely populated area, more multi-generational households, and a number of other causes. But ultimately, we face the brunt of this because of where we were, but also who we serve and the historical legacies of systemic racism on the community that we serve. Next slide. And so we really think about our ambulatory care program as a lever, one of many levers that the government here in New Jersey, both state and local, should be using to advance public health. And one of those very important areas historically has been infectious disease. And of course, the importance of those efforts only amplified during the pandemic. So between the Ryan White program, of course, focused not only on HIV/AIDS treatment, but a number of other things like care coordination and social services for folks suffering from HIV chronically, but a robust prevention program as well for infectious diseases in the community, sexually transmitted infections, but also really any infection that is more endemic here in Newark than otherwise. And very importantly, a strong clinical research arm that is very community focused. And one of the best things, frankly, we have on campus, which is our Research with a Heart program, an incredible team that is drawn primarily from the community here and equipped with the training and expertise to run clinical trials ethically and with robust community engagement. Next slide. And so just to give some sense of the scope of our Ryan White program, it's one of the biggest programs in the state. And we have thousands of visits per year in multiple different categories, total infectious disease visits, but also HIV in particular, importantly, and other visits around support for those suffering with HIV, medical case management, mental health, substance abuse, which is unfortunately a higher prevalence in our patients afflicted with HIV, as well as medical nutrition, especially for those with advanced HIV. And so we do the gamut of social services and really try to wrap around what we do for these patients, providing everything from care to transportation, financial assistance, psychosocial support. One of the programs we're really proud of, and something that has really shown promise and really tangible results and progress. Next slide, please. And so just to give you a sense of the broader scope of our prevention programs, in addition to Ryan White and what we do with rapid HIV testing and really all of our sites of care, we have programs around syphilis, around PrEP, an evidence-based intervention where folks take an anti-HIV antiretroviral therapy to prevent the contraction of HIV, where the evidence shows that it would benefit. And everything from condom distribution to outreach and post-exposure prophylaxis. We really do the gamut of services here for patients. Next slide. And so I mentioned Research with a Heart, doing multiple clinical trials in addition to the COVID-19 vaccine trial for Moderna that I mentioned. We are part of national trial groups, the AIDS Clinical Trials Group, the HIV Prevention Trials Network, and the HIV Vaccine Trials Network, are really just community-focused and in particular demographically focused areas of work that are just very important for the community, combining the necessity to do research with an approach that is compassionate and really takes social factors into strong consideration and involves the community in research efforts. Next slide. And so that was a great infrastructure to start with when it came to what we do and what we had to do by necessity when COVID-19 hit. In fact, we had a system of testing and of clinical engagement that quickly was reprogrammed to deal with the infectious disease and public health issue of the day, which was COVID-19. And so we've tested thousands of patients. We have a program that not only tests people and treats them for their acute disease, but follows COVID long haulers and really takes a multidisciplinary care approach for those patients as well. And we're building essentially a registry of those patients that hopefully will be fruitful for the cohort study and beyond. Next slide. And so this gives you a sense of recovery and follow-up. Ultimately, we had over 8,000 encounters in our ambulatory care setting in just the first 4 months. And so we've made sure to continuously follow up with these patients up to and including, but also beyond the COVID peak. And again, we are tracking through our electronic health record and other data capturing mechanisms, I think important data ongoing with clinical care that'll be informative on how to care for these patients longitudinally. Next slide. Our vaccine effort is something I will always be proud of throughout my entire career. We took the reins on this for the city. We've done by far more vaccinations than any other hospital in the city. And we did so proudly, even though we did so at a financial loss. That is the cost of doing public health work in many cases, but it's something that we just could not have, neglect. This was a community need, and I think we followed through. We fully vaccinated over 18,000 people in the community. We've given over 37,000 doses. And so that number continues to climb. We hope to break 20,000 doses, even though demand has dropped significantly. And we have a very high second dose compliance and an operation that runs 7 a.m. to 7 p.m., 5 days a week and half a day on Saturday every week, and has continued to run for that long and will continue for quite some time. Notably, we are rerouting our vaccination strategy to be much more in the community. So in institutions of trust in partnership with faith-based leadership and partnership with folks who run senior living centers and other areas where you have folks who want the vaccine but have an issue either because of disability or otherwise in actually showing up to one of these mega sites and getting vaccinated, or even to a pharmacy and getting vaccinated. And so very proud of those efforts. Next slide. And so how does this evolve going forward? I really believe that the earned trust over the last just almost a year now on vaccination and prioritizing the community when it came to COVID-19 will be quickly lost if we don't double down and re-engage in public health problems that have plagued this community for many generations. The fact is, a big source of distrust isn't in communities of color against the medical establishment isn't just because of historical injustices like the Tuskegee trial, or even just solely because of the implicit bias that people face every day in healthcare settings to this day. But it's also because people are looking at COVID-19, they're seeing that it affected everybody in society, and they're saying, look, somehow you mustered up the political will, the funding, and the all-encompassing engagement to eventually eliminate this public health problem in less than 2 years. So why aren't you doing that with problems that have plagued us for generations, like HIV, like chronic disease, like late-stage breast cancer being diagnosed in Black women at much higher rates than the general population because they're not afforded access to screening and education on the importance of mammograms. And so many other examples. The mayor focuses on men's health and the incidence, among many other things, of colorectal cancer in Black men and otherwise in this community. I mean, we have to continue to deliver on chipping away at these public health issues after the pandemic, or we will permanently be at risk of permanently, furthering the distrust between us and the community we serve. And that means focusing on social determinants of health, economic stability, building an environment around neighborhoods for care and preventative care. Health and healthcare is a component, but education and the social and community context are absolutely very important. Next slide. And so this gets to the definition of health equity, which is the attainment of the highest level of health possible for all people. And so a recognition of that isn't just focusing on race and ethnicity, it's focusing on what determines the disparities by race and ethnicity and health outcomes. And the fact is, clinical care, which is the bailiwick of what we do as a hospital, only accounts for 10% of what determines the variance in people's health outcomes. The rest are healthy behaviors, genetics, and social, economic, and environmental factors, where we do have the agency and ability as the quarterbacks of services, as hospitals, as anchor institutions, to move the needle on these efforts. The fact that we have people from neighborhoods with poverty rates of 30% who die 8 years earlier is an important example of that. The income disparities factor into this. Black infant mortality being twice as high. So we really have to get into more of the majority of that pie chart in terms of what we do as a healthcare institution. Next slide. And so this really aligns squarely with the strategic plan that was developed shortly before I arrived at University Hospital, and Commissioner Chris Kennedy was the interim CEO here. And what she did is she called upon not only the board and hospital employees, but the entire community to reframe our strategic priorities. And community health improvement is a pillar of that, and embedded and undergirded under all of our priorities is the mission of health equity. And so we won't be able to do anything on these areas without strong, very strong, trusting relationships with community. And that has been my focus since I've arrived here. And it was an investment that I made in my first 6 to 8 months in this place that already reaped benefits significantly in the COVID pandemic. Countless examples of the community showing up, whether it was donating meals to our staff or otherwise delivering donations and services and just honking for us and celebrating for our staff. That was a result of the investments we made up front in community alliances. And this isn't just money. This isn't just donating to certainly political candidates, but also projects in the community. This is showing up and actually gaining trust from people, that this isn't just about the bottom line of your institution. You consider yourself an economically empowering institution. And so part of that is increasing our procurement that comes from minority, women, and veteran-owned businesses right here in Newark. Part of that is showing up and saying Black Lives Matter when the rest of the city was in the wake of George Floyd's murder last year. And so many other things that have to be layered on top of the healthcare mission that we do. Next slide. And so this gets to the components really of what we've withdrawn from experts on how we're approaching health equity and how we're measuring ourselves in terms of outcomes. So we're looking at population health outcomes. This comes from the Johns Hopkins Center for Health Equity and IBM Watson, who I think really did a robust job in helping us define tangible metrics against which to hold ourselves accountable. And so we also look at the hospital, of course, as a healthcare provider. That means tracking our progress for diseases and illnesses by race and ethnicity, and holding ourselves accountable and our leadership accountable for closing those gaps over time. Very importantly, hospital as a community partner, whereby we not only, again, provide care, but we are economically empowering those around us by procuring from them and involving them in important ways. And then finally, as an anchor institution, and the last thing I'll mention, because I know my time's running out, is that we're at a really critical time of excitement here at University Hospital, because we've gotten a donation from this, appropriation from the state and the governor's budget to plan for a new hospital building and a new campus that will largely, hopefully, be funded by state bonding, but will capitalize on the improvements we've made here as a going concern financially. We've proven ourselves as more than, in my view, competent management to carry on this mantle. But importantly, we did so without doing so on the backs of the healthcare heroes and workers here, in terms of reductions in salary, furloughs, what have you. We didn't touch them because I didn't think that was appropriate. And instead, we advocated to our government partners to make sure we could survive the pandemic, and we did. We did get federal funding and state funding to be able to do that. And now we're full speed ahead with health equity really undergirding everything we do. Thank you very much. And if there's time, happy to take questions.
Thank you, Dr. Elnahal. You know, having been trained in safety net hospitals over the last 20 years in both in Chicago and New Haven, I so much embrace your mission and what you've said resonates so much with all of us. So, Ann and Oliver, do we have any couple question time, perhaps?
Well, we can probably take one question.
Okay. You can either type in the chat or you can, okay, I'm going to point to Dr. Steve Paskin.
Yeah, Shereef, excellent presentation. Just one thing I learned a few years ago about, and it's probably abundantly obviously consumer effort in healthcare. So it's difficult for persons to navigate health insurance, guilty as charged. It's difficult for persons to navigate hospitals, health systems, even independent practices. So how are you addressing that in this construct of social barriers and so forth? So just the whole difficulty with prior authorization, understanding what physicians are saying, that sort of thing.
Yeah, thanks for the question, Steve. And what I'll give you a little bit more credit than you gave yourself. I think we've had really willing partners and conversations with Horizon and other payers, frankly, who want to start to make progress on these efforts in a sustainable way. And I know that you're doing a lot in that effort. We're really proud to be an ACA navigator with the state. And so we make it as part of our normal business to ensure that coverage is maximized for every patient who walks through our doors. And not only to do that, but to advocate for policies that will cover more individuals over time. And so I'm very encouraged by progress being made in advocating for coverage for all children in this state, regardless of documentation status. I think that's just an important ethical and necessary thing that we have to do as a society. And so I think in as much as we serve the community, we're also a voice for the community when it comes to a seat at the table with state government and the federal government. And so I think part of that is advocacy, but a major part of that is having a robust, efficient operation that enrolls people in health insurance, whether it's Medicaid or insurance exchanges. We have a very large and well-equipped team to be able to do that, in part funded by a state grant that helps us do this work. So cannot leave that out of the equation by any means. And I appreciate that you brought it up.
Thank you.
Thank you so much, Shereef. And again, thanks so much for joining us. I know your time is precious and we're grateful for you spending time with us.